Well, on behalf of the Governor and Secretary Roberts, I want to welcome you all today. It's very evident from what you're going to see and hear about today that people have really done a tremendous amount of work since our last meeting. So on behalf of my co-chair, Dr. Professor Ira Wilson from Brown University, I want to welcome you and thank you. I'll make a few comments, then I'll turn it over to Dr. Wilson. The other thing is very much aware of this vacation week, but it doesn't seem to have dampened the enthusiasm or the attendance. So again, our appreciation for all of your efforts. And I'd love to say we're done, but I think you all know we still have a lot of work to do between now and April 30th and then beyond. I thought I'd review at the outset, where we've been. And I think most people know, but then there are people in the wings that probably might be hearing some of this for the first time. So, starting with our goal of the working group in terms of where we started in the marching orders that we were given by Governor Raimondo. Governor Raimondo inherited a $190 million structural deficit that needs to close. So that's baseline where we started. And I think you know that Medicaid makes up more than 30 cents of every state dollar and is a key driver in state spending, help the economy. A lot of factors come into play with that level of state spending on Medicaid. The governor in her budget included $90 million in state Medicaid savings in her budget. That's $180 million roughly in all funds in the state budget. That's a key point. And these were submitted as what I would call traditional straight cuts. And again, in my short tenure here in Rhode Island, 4 years is very short, I know in Rhode Island. That's what has happened every year. The budget comes out, there are cuts proposed, and they're fairly traditional straight cuts. So again, this year that's what was submitted in the governor's budget. But she really would like something very different coming out of this group. She was looking for this group to recommend really a better approach by identifying immediate savings for the FY16 budget, but also to lay the foundation for long-term sustainable reforms, and that's been the work of all of us. These reforms hopefully will shift Medicaid from a model that pays for volume, and I think we're all familiar with the fee-for-service system, to one that pays for better outcomes and value. And I think you know that this is happening all over the country, whether it's at the federal level or the state level. So, and she asked us to set out on a public process and really take a different approach, one that sought input from patients, providers, policymakers, and advocates. And I think that that's been part of the journey, as you all know. Finally, budget recommendations from this group will be offered by April 30th, and we will then turn our focus towards a longer-term strategic plan for Medicaid that transforms our system and spares us the unpredictability of continuing cuts and reforms year after year. In other words, we don't want Groundhog Day any longer. We want meaningful, sustainable reform, and that's really the charge of this work group. Now, we've had a number of principles of reform right from the outset. We've obviously set out on our work with triple aim in mind to improve the health of the population, improve the patient experience, but also to reduce costs as we do those things. And to achieve these goals, we focused on 6 guiding principles. One is to reduce fraud, waste, and abuse. The other is to pay for value, not volume. The third is to coordinate healthcare delivery across providers and systems. The fourth is to focus on high-cost utilizers. The fifth is to support transparency in everything we do and everything we talk about. And finally, to align Medicaid payment and purchasing strategies with commercial payers, state plans, and Medicare, effectively to modernize Medicaid, because a lot of these new approaches that you hear about today are already being adopted and a part of the landscape, whether it's commercial insurers or Medicare. These principles help us divide our work into 4 work streams, and a lot of you have been working on the work groups relative to these work streams. And that's really will be the product of what we hear about today. And so now I'd like to turn it over to Dr. Wilson to take over the next.
Great. Thank you, Dennis. So we've had a very interesting process so far. It's been a fast process, but I want to emphasize that to date this has been a public and a transparent and an open process. That is exactly what the governor and the secretary wanted. And today's meeting should continue in that spirit, in that vein. We actually started out with a meeting of the working group at which both the secretary and the governor spoke. We then, over the next several weeks, had a number of 4 open town meetings, one in Woonsocket, one in Providence, one in South Kingston, and one in Newport. Started in the south, in the north, and went south. Those were tremendously interesting and tremendously well-attended meetings where Medicaid recipients, Medicaid providers, lots of different people had not only the opportunity to tell us what their experience has been, but also to give us ideas. And we asked people from the very beginning to send comments, suggestions, proposals, and at this time we have, at the last count, was more than 175 suggestions. Indeed, even last night as we were preparing for this meeting, more suggestions were coming in, which is really tremendous. And as Dennis noted, we broke into 4 sort of work streams, one on behavioral health, one on delivery system reform, one on high utilizing patients, and one on long-term care. And let me just say that I really want to thank everybody who's been participating in those groups, because they've all happened before and after the normal workday, and they're all on top of all the really important work that members of the work group and others are doing anyway. So our goals for today really are to continue this process. First we want to thank Deloitte, who is facilitating today's conversation. They're actually donating their time in order to do this. It is not at all simple to figure out how to have an open, fair, and reasonable and honest public discussion of so many things about such a complex topic. But fortunately, Deloitte knows all about how to do that. We continue to look for open feedback about the proposals that you all will hear about. In particularly, if there are errors of fact or errors or perspectives that we're missing, it's utterly critical that people dive right in. A lot of these proposals are being developed really rapidly in real time, so if there's any mistakes or any errors, please jump in and correct it. We have 8 days to finish and make some substantive recommendations on all these things. So by the end of today, we will presumably make a lot of progress and have a lot of good, fair dialogue, but there's a lot yet to do. And I just want to say a couple more things by way of framing. So first of all, we're cutting money, right? We're asking providers essentially to take cuts and to participate in helping us figure out how to do that in a way which is fair and reasonable and prudent and will not hurt Medicaid patients who are among the most frail and vulnerable and disempowered members of our state. And I just want to say, and I think the Secretary and Dennis would agree, that it is no simple thing to come forward and help design a way to reduce something that you may not necessarily agree with or you may only partially agree with. So we really appreciate the spirit of collaboration and sort of communitarianism that people are doing this with. And lastly, I just wanted to say that healthcare in Rhode Island is really quite good. And there's no assumption here in anything that we're doing that healthcare is bad and it needs to be good. It's good and it needs to be great. And I hope that we can all participate in these discussions in that sense. So with that, let me just turn it over to the folks at Deloitte.
Thank you, Art. I mean, this may not reach me. I may just see if you can hear me. Let's put this down one step. I want to start with a couple thoughts for everybody.
Rhode Island has the second highest per enrollee Medicaid cost of any state in the country, which is 60% higher than the national average. So from the governor. Second thought. The health of the people is really the foundation upon which all their powers as a state depend. That's from Benjamin Disraeli, a British Prime Minister. The last one. Good humor is the health of the soul. So as we begin our discussions today, the first two, I think, echoing Ira and Dennis, what you said, is the balance you're trying to find today. How do you control costs but make sure that the health of the people is maintained? And the third one is just knowing, as much as we can today, remember to smile. Be in good humor. To summarize the objectives that we have in the next couple hours. Align on the definition and impacts of the critical Medicaid FY 2016 initiatives, number one. Number two, gather feedback on opportunities and challenges associated with those initiatives. And number three, align on next steps. Two ground rules. First, we invite you to be present here. You are physically present. We know all of you have emails that are building up in your account as you sit here. We ask you to, as much as possible, be present with your colleagues here today and focus on the interaction that you're going to have today. And the second ground rule is be open and honest. We're going to provide a forum that should make that very, very easy. But this is really an opportunity for all of you to share truly how you feel about some of these initiatives. Here's our agenda. You in the back may not be able to see it, so I'll describe it. First thing we'll do is describe the initiatives. Make sure that we're all relatively clear on what they mean. It may feel a little bit messy. Then we're going to share some ideas with each other about those initiatives. And from those ideas, we're going to look for themes and maybe new thoughts that the state can take forward with these initiatives. And then we're going to repeat it. So we're going to talk about some of these key initiatives, brainstorm, find the themes, and then repeat for the next one. We'll do that for several of the most significant initiatives, and then we'll maybe look at some of the smaller ones in groups later on. A couple other things about the agenda. You have 55 initiatives. We have 2 hours, and we could probably spend 2 weeks, maybe 2 years, talking about them. So we're going to go uncomfortably fast. One of my jobs and the co-facilitators is to move us on more quickly than we're going to be comfortable with. And that's okay. You will have some additional time after this meeting to get back to the Secretary's office to share any other thoughts that we may have missed today. But just be prepared that we're not going to have enough time to really thoroughly explore each one of these. But what we're looking for is really your most urgent, most important thoughts you want to make sure that to get out today on the topics that we covered. Okay. And the last point is that we normally like to take a break after an hour and a half. We won't do that today. We have a lot of content we want to cover. So we understand that people may need to take breaks. Feel free, if you have to take a break, just get up, leave. The restrooms are out to the left, and come back as soon as you can. Okay. Sort of the administration piece. Is there any questions, concerns about the day so far? Okay. So we have one.
Hold on a minute. Yeah, sorry, go ahead.
Yep, come back.
Is there a list of all the initiatives that we're going to be discussing today?
Yes, there is. It's on the website. I'm looking for Matt.
So the full list of the initiatives have been distributed to the members of the working group, and I think after this meeting, we will put it on the website for everyone.
Thank you.
Stay tuned. Okay. With that, Deidre. think I'm handing off to you to provide a little bit additional context. Do you want the mic?
Good afternoon, everyone. I'm Deidre Gifford with the Executive Office of Health and Human Services, the Medicaid Director. Before we start talking about some of the specific budget initiatives, I was just going to provide a little bit of context for what we've been hearing throughout the conversations with our 4 work streams and the input that we've been getting from the public to sort of frame up the context of the initiatives that you're going to be hearing about and providing your input on. The first thing is to remind everyone, you've heard this a couple of times, that this is the specific initiatives for the coming fiscal year are a blend of initiatives that are required to meet the budgetary imperative that we have, and initiatives designed to lay the groundwork for a longer-term set of broader reforms. And I think we've had a nice combination of contributions during this process of short-term initiatives, but things that will also build and lead towards longer-term structural reforms in both the way we pay for services in Medicaid and the structure of our delivery systems. I wanted to just highlight a couple of the themes that seem to be coming out. One is around elimination of duplicative and similar programs and trying to streamline the number of things that we're doing within the Medicaid program across fee-for-service and managed care. And I think you'll start to see that theme come out in these initiatives. To consolidate services around the member, so you're going to see some initiatives that talk about bringing out-of-plan services into managed care. We have the majority of our members in managed care plans, but we continue to have paid for some of our services through the fee-for-service delivery system. And that was a theme that we heard multiple times to sort of consolidate the funding around the individual within a plan. One of the major themes was around developing accountable entities that would be responsible for the total cost of care for our members. So bringing services in plan is a way to do that, but also thinking about building structures within the Medicaid program in the medium to long term that designate a group of providers who would be responsible for the total cost of care for a population of individuals. That was a common theme in most of the working group meetings. And then the final 2 are ones that we've been discussing all along, focusing on behavioral health care and the importance of behavioral health conditions for the Medicaid population, coordinating those services with physical health care and social services, and focusing on our highest utilizing, highest need members. So with that, as sort of the context and the direction that seems to have developed and consensus that seems to have developed through this process, we'd like to walk through a few very specific initiatives for your feedback.
Okay, so right before we get in there, committee members, we asked you if you came in to grab a picture. So to get you a bit more in the mood of the type of conversation we're hoping to have, if you just spend a minute or 2 with your neighbor, sharing why you picked the picture you picked.
If you didn't get a picture, they're over here on the table.
Take 1 to 2 minutes.
EVV is coming. I'm talking. Electronic going to pay for it. The state wants it. The state pays for it.
Right, we can't pay for it, so it's the reimbursement that we have. They think they're gonna save money.
Well, except for the ones that they should have shut down.
The objective here is to block the road too.
We've got about 30 seconds. Y'all interested, as you've just finished with the conversations, is there,
Oh, you fell asleep.
did you see a theme amongst yourselves as you talked? Was there something that jumped out as your conversation you think that we should share?
Well, we had a great combination of cards. I picked this baby, it was the cutest baby, and I can't believe it was still there waiting on the picture. Because I think we have so much good work to build on, through the work that we've done with the Right Care program over 20 years, and the health and well-being of this child, of the Medicaid program, maybe through the door of Right Care, where children with special health care needs. And we just have a lot at stake trying to continue our very high-quality, great work for this children and then the other children. And then Lena had a great card too.
Oh, so it's the gearhead card, and at first we looked at each other and thought they have nothing in common, but, my point was really around making a very complicated system work as seamlessly and as smoothly for the networks as possible. And there's a lot of complexity, but I think sometimes the idea of taking cost and complexity out, we think about the budget side of it, but really it should be about serving these networks more effectively.
The gears working together to help that baby have a healthy future. Great, thank you. Anyone else that want to share?
There's a bunch of fish, so I think because there's a lot of people who are fish get eaten by the larger fish. So it's pretty heavy white, pretty heavy male, pretty heavy. So we probably are not on Medicaid. We're making a lot of decisions about a lot of people who are receptive, not many who are sick.
Making sure,
Most of us, probably 100% of us have private.
making sure all the small fish are really taken care of.
Yeah.
Protected from these things. Great. Okay, very good. Thank you for that. And now I will hand off to Andrew Stein, who will take us down to the conversations around the actual initiatives.
Good afternoon. My name is Andrew K. Stein. I'm with Deloitte as well. Flew in from Atlanta to be here. I'm a Brown grad as well. So the first thing you notice is we handed out some iPads for those of the working group. These are not yours to take home. We're going to need them back at the end of the day. If there aren't 30 back in the box at the end of the day, then I get a pay cut. So we'll be using that in a moment. We're using this tool to allow us to basically download the brain of the group simultaneously. For those of you in the peanut gallery, you will see the input that the working group is sharing as it comes on screen. I apologize if you're in the back, fonts might be small, you might not be able to see everything. I believe the report will be available after the session as well. The first thing we're going to do is show you, the working group members, how this works. All right. So in a moment, the question is coming up on your screen, and it reads, what's your favorite Rhode Island vacation destination? What's your favorite Rhode Island vacation destination? So here's how this works. There's a text box there at the bottom. Tap it. A keyboard should come up. Type in your response, and hit the return key on the right. All right? 5 more seconds for any last ideas. If you're trying to decide between two. By the way, if these are iPads, they're technology breaks. If you're having trouble, it's not doing the thing it's supposed to be doing, raise your hand, and colleague Logan, raise your hand, Logan, will come around and swap you out one, kind of like in a tennis match with tennis balls and those guys who run in and out. But with iPads. Okay, so Narragansett out with an early lead. Newport, Nantucket, I can't pronounce it. Petunic, thank you. Westerly, Black Island, love it. Providence is not, just one Providence. Two, okay, all right. By the way, so for those of you who just voted, tap the, there's a sort of a closed keyboard button at the bottom right. If you tap that to get rid of your keyboard, you can see the full list. And then this is important, two-finger scrolling. This is the only iPad app you'll ever see with two-finger scrolling. Use two fingers, press firmly on the screen. You can use go up and down to see the whole list. Two-finger scrolling. Perfect. So look how fast that was. If I had gone around the room and asked every single person, favorite vacation destination, we would have been here for 15 minutes. But by asking them, what we've done is by making this sort of chat room, we've turned what's usually sequential into something simultaneous. So that's why we're using this tool today, to sort of very quickly, simultaneously, see what you're all thinking. The next question will probably require perhaps a bit more thinking. Should be coming up in a moment. And it asks about our legacy as a working group. How would you like this working group and the Reinventing Medicaid initiative to be thought of by a future generation? What should our legacy be? Tap in the text box, type it in, hit return. Set Rhode Island on a path to an affordable, effective Medicaid system. Real long-term change. New kinds of conversations. High-quality, patient-centered care. Achieve the triple aim. Does anyone want to say what the triple aim is?
Better health, better care, lower cost.
Thank you. This is great. So please keep this in mind as we move through this today. So next is going to talk about 6 of our most significant initiatives. And I believe to tee this up, we're going to talk about the first. We have
Dennis is going to talk.
Cue me up. So this is one where your input will be very, very helpful. It's the impact on all funds is 31 million out of 108 million. So obviously it's an important initiative. And what I've experienced is when the state budget comes out the past 2 or 3 years, even though there was, I guess, some history where there was actually Medicaid rate increases. The past 2 or 3 years, there's been no Medicaid rate increase. Medicaid fees have been frozen. And the difference this year is certainly no increase again, which is roughly around 2%, but also an additional 5% rate cap for Medicaid to be spread across both fee-for-service and managed care programs. And the Hospital Association of Rhode Island, Mike Suze is in the back. We worked on this together, and if any of it's wrong, you can blame Mike. But really, we want to do something different. All of us can always go to the assembly and try to lobby down whatever's being proposed. So, maybe we could go and lobby down and maybe, get it to 2 or 3%. That's really not what we thought would be the right approach. And again, following in the footsteps of the Medicaid value-based purchasing program, we thought instead put that 5% in a pool. And that pool is the $31 million. And if hospitals can actually improve care in fundamentally different ways that really help reform the system, deliver better health care for our most vulnerable citizens, in doing that, really achieve certain goals, objectives, and metrics that we would commit to right up front, hospitals would be able to earn back some of that pool. The other part of this would be that the pool would be set aside by the state, but it really wouldn't be paid out till the next state fiscal year. So there'd be real savings in this state fiscal year of the $31 million. and any payout would come in the next fiscal year. Hospitals would be fully at risk for the pool. If we did a very poor job in meeting the targets, the state would really not have to pay anything back. The other benefit here is metrics that we would choose, and we still haven't developed them yet, would be things like reducing unnecessary ER visits, reducing or preventing hospital-acquired infections, reducing preventable readmissions. I mean, there's a number of established metrics that are out there, Medicare has them in particular, that we would target in terms of, how do we really access the dollars in this pool? And any additional savings to the state would be if we do reduce, unnecessary care, care that doesn't provide value, care that is not helpful to improving a patient's quality of life and overall health. If the state actually saves those additional funds because those services are not paid for. So that's, in essence, the overall proposal. Medicare does the same thing. Medicare being Medicare, they take 3% right off the top, and we're lucky to earn it back if we do similar things, and it's the way their value-based purchasing program works. So why reinvent the wheel if we have something that's been tried and true? And every year Medicare adds to the metrics, actually makes it more challenging to really have systems meet the metrics and create sustainable healthcare reform, which is what I think we're all here for.
Thank you, Dennis. And so we're going to be going through 6 of these ideas. I'm going to take a quick time out to give you a process update, and then we're going to jump right back into this initiative. So we're going to do a 2 or 3 minute spiel about the initiative, just like Dennis did. Ask for any clarification questions. We have time for just 1, maybe 2. And then we're going to be asking you guys a question in Think Tank. The question is going to be, what can be done for this initiative to have the greatest impact? After we gather your feedback on that, we'll ask a couple of our Deloitte experts to make some commentary, identify some things they've seen, and then we'll move on to the next initiative. And we're going to try to get through each one in about 10 minutes. So we're going to move pretty fast. We have an aggressive agenda. So already we have a question, Dennis, I'll put this to you. How are we going to reduce costs without putting more work on fewer staff, nurses, CNAs, techs, etc.?
Well, I think the reduction in the costs would, in and of itself, require less services to be provided. So I don't see where that necessarily relates to the concept in general. So the whole idea here is to really reduce unnecessary care, and that actually, in and of itself, makes it less burden for cost. Now, well, I'll just stop there.
And one more question for you, Dennis. How much of the $31 million can hospitals potentially get back to the group?
And again, we haven't really pinned that one down yet, but to me, it should be full risk. The hospitals can get it all back, but they can lose it all. So the better we do, the better all of the hospitals do, and the more meaningful reform as a result. So that's the opportunity. But if we do very, very poorly, then we're at risk in terms of the full 31 million.
So now, I invite you to, first, as a reference, this is just the name of the initiative. If you want to just see a little paragraph about it, you can turn to page 4 of your reader in front of you, where you'll find the idea as D002. And what I invite you to do now is to use Think Tank, tap in the text box, and answer this question for us. What can be done for this initiative to have the greatest impact? I'll give the working group about 2-3 minutes to give us their ideas, and we'll keep going. All right, 5 more seconds for any last ideas. Get a little bit more typing. Let's do a little more time. Hit return on your idea. And while you're doing that, Sally, got our sort of Deloitte expertise.
Jim, what are you seeing coming in?
As we're looking at this, I mean, I think one of the comments that was made here was this idea was this change has to happen fast. That this does, I mean, according to number 4, if you look on your thing, it appears as though this requires a statutory change and would have to happen quickly so that you could see those actual changes. The other thing that comes through here is there are a lot of states who are doing this right now, and they've established benchmarks, they've established how they're going to do it, they've adopted coding systems, et cetera, and there's a whole list of them out there, and I think you can find something that'll fit best with Rhode Island's way of doing business and customize it if you need to. Anything else? That's it.
Jim, tell the good folks where you're coming from today, what you do.
My name's Jim Jones. I'm a subject matter advisor with Deloitte Consulting. I spent 31 years in the state of Wisconsin. The last 5 years as a deputy director for Medicaid CHIP and the staff director.
Can I have one comment to that?
Yes, please.
I'm Tom Steiner, also with Deloitte from Minneapolis, and the one item I'd add is the initial comments here were we don't want to just have cost savings, we want to have a better program to the extent we can for our Medicaid population. And this is one of those items that's in line with that kind of thinking. It's not solely about a kind of savings, but it's really looking at what kind of care should be delivered. So if we have overutilization, certain services, or we're having high readmission rates that shouldn't be occurring, there is a way clinically to look at that that can be joined with financial outcomes as well. And it is an example of improving healthcare while saving money, and that really is the focus of what this session is about, from what I understand from Dr. Gifford as well as Secretary Roberts' meeting this morning. So it's in alignment with what you'll be hopefully talking about and thinking about as we go through the afternoon.
Thank you. So that's how we're going to go through the initiatives today. Quick FYI, we've got 5 more that we're calling the most significant. So we've just tackled number 1. These are the next 5 we're going to go through in order. And I believe Matt is up next to talk about nursing homes.
One other thing, Richard, before, so just know that you're going to get back everything that you're putting into think tank. That's all going to come back to you. So you'll get a full report.
So there were 2 essentially large initiatives in the original government's budget proposal that were implemented in terms of a rate cut. The first was a hospital rate cut that Dennis talked about, and the second was a cut to nursing homes. So as Dennis described, hospital solicitation came in with a proposal to take that rate cut, take that money and reinvest it in a program that would help to, over time, transform the way we pay hospital services into one that's more based on value rather than on volume. So what we've tried to do is take the same sort of model that we just saw in the hospital approach and apply that in the nursing home. So the proposal is very simple. To take the $18 million that would be generated in savings through the 3% cut in nursing homes, and invest that in an incentive program for nursing homes that's designed to do 3 things. Well, 2 things. One is to try to reduce or avoid long stays in nursing homes where appropriate. To do that through either incentivizing discharges to the community where appropriate and by avoiding rehospitalization. And the second is to build a set of quality incentives where nursing homes could earn additional payments by meeting quality metrics. Very similarly, the particular metrics, what the measures are, and what the mechanics of the incentive program will have to be worked out in concert with the providers. But that's the basic structure of it. So there's the dollar amount, there's the...
So at this point, I'd like to ask for any clarification questions from the working group.
And Andrew, they can raise hands, so right? They don't have to come in and think.
Yeah, exactly.
You're allowed to talk.
So the hospital initiative indicates that the money would be earned back in the next fiscal year. What's the plan for the nursing home?
It'll be the same structure.
Same thing.
Full risk, just like the hospital approach, the 18 million?
That's the way we're describing it.
And so, if you haven't already, please tap in that text box, and the question again, what can be done for this initiative to have the greatest impact? Take a couple minutes, share your thoughts, keep going. Sally and team?
Hi, I'm Sally Finger, also with Deloitte. I come from Minneapolis, but had the great fortune of running a very similar initiative for the state of Wisconsin when Jim was actually our client there. So I'm happy to be here today. I'll just make a comment. I think it was on number 11. We had a very similar initiative in Wisconsin around this initiative. And 11 talked about the quality metrics that need to get implemented for the coordination of care to the least expensive setting. And one of the ways we actually implemented that was doing more regular acuity assessments within the long-term care settings for that. So I know we're not to the implementation stage yet, but that'll be a really important one, and bringing I think it touches on another one about bringing the nursing homes and the other groups to the table as you're developing those quality metrics was something that we really focused on and made a difference in terms of implementing this initiative.
Also, I just want to hit one other theme that I thought was really interesting. This is a really new way of doing business. There are a lot of states that are doing quality initiatives in this area, but I do think that the idea of doing regular assessments, collecting data about individuals, and then putting them in, I thought I saw it in the themes that somebody was writing down, right care, right time, right person. Right amount of care would really, that's really what's really being added, really being focused on here. Also, the whole idea here is, it's not necessarily earning the money back, but in many ways, the whole idea here is, let's put people in the least restrictive setting, let's put them in a setting where they're the most comfortable and they get the best care, and that should result, especially when you talk about things like fewer hospital readmissions, it should result in a lower overall Medicaid cost. So if you talk about this thing as a one-time thing, not a one-time thing. This is going to have to be an ongoing effort, and it's going to probably require mid-course corrections over a period of time.
Thank you. So that was great. As you can see, tremendous quality of ideas. We don't have time to go through nearly most of them, but I want you to know they're being captured, they'll be shared back, and the staff team is going to be using those as honest feedback to sort of hold themselves to the fire of what we need to do.
When you say answer back, does that mean you'll give us an answer?
No. I meant we're going to share back the content of the answers.
How do you get an answer to some of the questions then?
The answers, John. So if some of the feedback is factual questions for staff to answer, we will absolutely respond to those. But we're also, the key thing is that the feedback that we're capturing here is going to be made public and available for everyone to review. But if there are questions that we can give concrete answers to, we will ask them.
It will also, I would say, be if there is a question that appropriately challenges an assumption that's being used to make a decision, then that will be the way that question has a significant impact. And I think some of these questions are intended to do just that.
Good question. So moving on to number 3, home stabilization initiatives. I'm going to call on Deidre. And by the way, because you have the new think tank question on your screen as well. If you have a question for Deidre as she's talking, feel free to type it in and draw questions from there.
So this initiative combines a number of the larger themes that I mentioned earlier. It has to do with focusing on high utilizers, high need, high utilizing individuals, focusing on the intersection between utilization and behavioral health, and looking at social determinants. And one of the things that we've heard a lot from all of you during this process is that sometimes the program will need to invest in different types of services in order to achieve savings in other areas. And this initiative falls into that category. One of the things that the challenges that our members face, and what we've heard about most consistently from all of you in talking about developing new delivery systems and the challenges that you face in reaching our members is the issue around stable housing for recipients of Medicaid. And all of you in the audience that are providers understand that this is a difficult challenge for us and that it has very measurable effects on utilization. A lot of emergency department utilization, inappropriate utilization of specialty and pharmacy services that could be lower intensity services, et cetera, et cetera. So this initiative would put into place a set of services through our 1115 waiver and in partnership with our managed care partners. Services that would assist individuals in moving into stable housing. It's not an initiative to pay for housing, but to really help facilitate connections with housing and provide services around getting our members into stable housing that will help them achieve the housing and remain in housing so that the beneficial health effects of that can be felt in the rest of their service utilization. So that's what this initiative is meant to do.
Thank you, Deidre. We had one question come in. And it asks, if this makes sense to you, is least restrictive community based actually possible without hospital affiliation?
Can you ask her that question?
Where will EO-HHS get funds to support this initiative? Is it related to HUD grants?
So this is, as I mentioned, this is a example of a place where we will have to invest funds in order to save. So the theory is just like within, for example, investing in primary care and community health teams that you're going to hear about shortly, that we will need to spend some dollars on new services in order to achieve savings in other areas. So the funds will be in our budget and they will support this new service with the assumption of reductions in other spending.
And any additional clarification questions from the working group?
The one I see here a lot is more about actually understanding where the savings are generating from. There's a couple there.
Right.
Can you speak a little bit more? I mean, you mentioned that, but.
So the individuals who have unstable housing tend to not use primary care services. They sometimes don't use any outpatient services other than the emergency department. They tend to have exacerbations in chronic conditions because they're not accessing the appropriate level of outpatient services. So the savings are, the hypothesized savings here are based on appropriate use of primary care and specialty services when needed, appropriate access to behavioral health services, more consistent pharmacologic therapy so that individuals don't need to use the emergency room and inpatient facilities as much as they otherwise would, and that their chronic conditions are under better control because they're accessing appropriate services.
All right. Any more clarification questions?
Does this need approval from CMS or is that already approved? It's in the 1115 waiver, so it will need federal approval. It's not yet. Okay, I wasn't sure what the status was. Thank you.
So if you haven't yet, go ahead and tap the text box. Tell us how we can help this initiative reach its utmost success. You'll have a turn for us. A couple minutes for that.
One thing I'm noticing a lot of questions, so feel free to keep making suggestions and other considerations. If this isn't just for questions, it can be for ideas you have on how to make it better, a way to implement it, a wide range of thoughts that you have around it to improve the way it's implemented.
So as you finish your last few comments and what your colleagues have put in there, we'll call in our expert corner. Yeah.
I wasn't part of the high utilizer work group, but I think there's a lot of evidence out there that the small percentage of the population, Medicaid and otherwise, really consumes a large percentage of the resources. 20% maybe consume 70% of the resources. So I was surprised at the modest savings here because this is an area where the investments could be significantly higher and really reduce the expense to a far greater degree. So I don't know if anyone from the high utilized work group wants to comment on that. I'm sure it was discussed within your group. Oh, you?
So at 7 o'clock or 7:30 tomorrow morning, the high utilizer group, which by the way goes by the acronym HUG, is going to meet, and one of the main agenda items is to try to understand essentially the business plans that underlie the series of things we've heard about, which are along the lines of very aggressive, ambitious case management of high-cost cases. And so I actually agree totally with Dennis, but until we sort of crunch the numbers, until the people who are actually implementing those programs tell us if they were to expand it, to scale up as it were, what that would involve, how long it would take, and how much money it would save. It's a little bit hard to know, but in principle, I do agree.
All right, so HUG scheduled tomorrow, 7:30.
A few items to note in terms of the initiative itself, really looking at the complex, high-cost need that you have in the state, and looking to integrate that care. Now, we're really talking about housing here, but behavioral health, physical health, acute care. These are things that states are looking at more and more in terms of really integrating what we're doing with behavioral health. That's bubbling up as a high needs, high cost group. And here's an initiative trying to look at that group and more holistic approach in how we're working with them. Another item that came up, a few of the different comments is, can we repurpose long-term care beds if we have an open wing? Is that a potential option for the state to consider in providing that care?
Thank you. So, halfway done, turning item number 4, and this one is about scaling up community health teams. And as usual, you can type in your comments, but also allow audible comments right after you do this.
So the community health team concept is something that's actually being piloted as we speak in Rhode Island. Community health teams are groups of support staff that are affiliated with a medical home or a primary care provider or an accountable entity in the future. And they are comprised of staff that can assist the primary care medical home or the accountable entity in addressing some of the very complex social and environmental needs of some of our most complex members. So right now, through the vehicle of our Care Transformation Collaborative, which many of you know is our multi-payer patient-centered medical home initiative, we have a community health team in Pawtucket and we have one in South County. And they are comprised of community health workers and licensed behavioral health clinicians who are working with groups of high-utilizing individuals who are identified by our health plans, and lists of these individuals who need particular intense care coordination and care management are sent to the community health team and the patient-centered medical home care coordination providers. And they are working together to meet those members in their homes, to go to medical appointments with those members, to connect them with social services around food, around transportation, around housing, around heat, all of the health-related social determinants that we know are impacting people's health behaviors and their health outcomes. So we have, this idea was borrowed from some of our sister states. It's been scaled up statewide in Vermont and in Maine in the Medicaid program. And there's a lot of optimism about the capacity for community health teams to really be an adjunct to the accountable entity and the patient-centered medical home to provide those social services in an organized way. We also learned during our conversations that we have a lot of elements of community health teams sprinkled throughout our system. And that if we can capitalize on some of those resources and put in a structured community health team plan for the whole Medicaid program, we can probably scale this up fairly quickly. So that's the community health team, and we would have $2 million in savings. So, $2 million.
Any questions from the working group?
So, questions about the relationship between community mental health organizations, community federally qualified health centers, and community health teams. Definitely, one of our FQHCs now has built their own community health teams. So we want to make sure that all of our high-volume primary care providers have access to this service, and that would include, obviously, our members getting services at both of those types of providers. Do we have any outcomes from our current CHT regarding quality improvement and cost reduction? They've only been in place for a few months. Our health plan partners, I know, have been looking at results and have seen very positive signals about utilization for the members who we've been able to contact through the community health team. We have lots and lots of anecdotes about people who have fallen out of care or are not being reached and are being reached through this mechanism of the community health team. We don't have hard and fast numbers, but we have a lot of growing evidence from Rhode Island and other states that this is an effective mechanism. And there's a couple comments about all payer, and our two in CTC are all payer community health teams. That's also the model in Vermont, so there is the opportunity. And we have some SIM dollars that are focused on community health teams as well, so there is the opportunity to continue to build that as an all payer space.
Any last questions? Yes.
This is the direct piece of we're talking about. We're going to be also hospital-based location at home.
The question, for those of you that didn't hear it, was the relationship of the hospital to the community health teams. And I would say that one of the primary areas of focus for the community health team is around that transition out of the hospital. So we're looking at ways to use current care and hospital alerts to notify the community health team that one of their members has been either admitted or discharged from the hospital, so the answer is yes.
You know the drill. Tap in the text box. Let us know how we can improve this initiative, help it reach its greatest potential for success.
Oh, sorry. So I'm going to touch on, there were so many, this sort of ran the gamut, I think, but a couple of them I want to just briefly talk about it. You mentioned some of the neighboring states that you've looked at. I mean, this is really happening everywhere, but I think one of the reasons we don't see a lot of data on the cost savings and the return on the investment and sort of the quality metrics is because it's happening everywhere and not coordinated. And so I think to Deirdre's point, you're looking, part of this initiative is to look at this and bring the structure of the program, bring the training together, bring all of those procedural parts of this project or this initiative together so you'll have better data. I would just say that there was a couple of comments around defining the quality metrics associated with it, and then I mentioned the training piece, but again, the comment about the 1,000 flowers blooming, I forget which, number 10 or something, I think that's a perfect synopsis of, you know, it's yet another initiative. That's great, and let's see what happens, but without the part of this initiative, without the structure of bringing the actual program together and creating a structure around it, and I think you guys are in a great place to do that, has to be part of the roots of it versus just another initiative.
Great list of ideas. Thank you. So we're going to move on to community health teams, to a couple of twin initiatives that go together. Moving out of plan services for children, the special health care needs of managed care, and redesigning CEDAR's services program, transition to community health and community care.
So this pair of initiatives is, this was the theme I mentioned earlier about bringing all of the spending for some of our highest need members into managed care so that the total cost of care can be accounted for and that all the services can be managed and coordinated. So right now, for our children who are in Medicaid managed care, certain of their services are still paid for by fee-for-service Medicaid. So what we would like to do with this initiative is move those services into the health plans and allow the total suite of services for those high-need children to be managed through a single payment structure. We think that will benefit the children and the families, and it will also allow us to have a single place where the total cost of care is being measured, monitored, and tracked. The second part has to do with our CEDAR family centers, which are care coordination and service delivery kind of intermediaries for some of these same children with special health care needs. What we'd like to do with the CEDAR program is align it with the community health team initiative that we were just talking about, and think about the CEDAR centers as a resource that's more closely aligned with our pediatric practices, as well as the providers of the home and community-based services for children. We are launching a patient-centered medical home initiative for kids within the next year or so, and we would really like to see the CEDAR family centers align with that initiative so that we can make sure that we're moving towards this accountable entity type of model where a group of providers are really accountable for the total cost of care. And without making some of these adjustments, that will be very difficult for administratively to make that happen. So that's the explanation behind it.
Any questions? Clarification questions?
So, do you need an update or?
Either way. Please raise your hand, yeah.
Oh, just a quick clarification, because this is, it's talked about a lot, children's behavioral health care needs, critical area of care for kids and very, very important to families. As that shift happens, I assume the number behind this is that the dollars that are currently going into fee-for-service for children's behavioral health care needs would shift in plan? That's right. Thank you, that's absolutely right.
And in terms of some of the assumptions behind this, we think that there is opportunity for us to make these services sort of update and upgrade the services and make them more based on evidence, the current evidence around home community-based services for some of these children. And we also think that the management and coordination could be optimized for some of these children, and because of the separate nature of the systems, we haven't really been optimizing that coordination, and we think both of those things will result in some modest savings to the program.
Any other clarification questions? All right, now we get to turn it back to you. Let us know what we can do to help this initiative achieve its brilliant possible success. Type it in and hit return. Hit return on any last comments. Some great feedback there. Thank you. This is really, really helpful.
Okay, as we were looking through there, I mean, it's easy if you just read through them really quick. There's tremendous concern about the ability, capabilities, and capacity of the MCOs to take on this challenge. So that's going to have to be a real focus of the implementation effort and the planning effort. The second thing is, it's pretty clear to me, I mean, we were reading over here, this is about the most liked idea we've seen. It seems like people support this idea, like it, would like it to be more family-centered, worried about the MCOs, but the real question again, and it's about it, all those things, can you implement it? Can you get this to work? And can you do it in a way that you evaluate it later to make sure it's a true success?
Thank you. Great. So we're going to move on to the six ideas. This one about mental illness. Coordinating care management for those with severe and persistent mental illness.
Hi
I'm Marie Montanaro, the director of the HCBA. Our behavioral health work stream has been working on the redesign of the current integrated health home for adults who live with a serious and/or persistent mental illness. That health home program, which has been in effect for the better part of 2 years, really hasn't provided the kinds of results that we would expect to see in the management of this population. So we've taken on a redesign of that based on some national evidence of models that have occurred in Missouri and Iowa in particular, which are two of the states that have gotten out in front for several years on the integrated and whole health management of this population. While this group is complex and it is a high utilizer group, it has been designed in our committee, but it still has many of the elements that Deidre already discussed about how you approach high utilization. The idea for this program is that the right door for primary care is typically a community mental health center for people in this population. The complexity of their needs and the services around which they receive, which have to be coordinated, are so complex that they typically are not well understood or managed at the primary care level. They really take a specialized approach, and our community mental health centers have been providing specialized care to this population for a long period of time. The model, we hope, will be driven through managed care. The savings number of $6 million all funds represents a reduction in 3% of the total cost of care spent in Medicaid for this population, which is about 10,450 people, in the first year. We hope to negotiate with the plans to receive that savings up front by the state, and we're not at the beginning of this initiative, so typically PCMH initiatives take 3 or 4 years to produce results. There are actually a lot of these pieces in place already. The model will focus on a care coordinating team. It looks a little bit different than a normal PCMH team because it includes peer support counselors and a heavier emphasis on behavioral services, social case management than you would see in another model. It will focus on results, outcomes, and utilization, and it will meet our health home, our integrated health home providers where they are today. So some of them are really at the beginning of their understanding of population-based management. Some of them are far along and they're in integrated systems. One example of that is the Providence Center with Care New England. We're creating 3 types of payment systems to meet the providers where they are. At the beginning, it's more of a fee-for-service and incentive-based model, and at the other end of that spectrum, it is an accountable care shared savings payment model. The work group is now putting the finishing touches on the strawman design. Then it will be all about implementation, as the group has said. And we have very particular ideas about how we will engage the plans, how it will look in the re-procurement, what the integrated approaches are between FQHCs, who manage the medical services for a great number of these individuals, and the CMHCs. Many of them are already working on that today. And I'm going to get the hook in a minute, so I'll just stop right there and take any questions you have. Thanks.
Feel free to raise your hand. Any clarification questions for Maria? Once? Thank you. Any of those comments? Yeah, looks like we jumped right into comments, which is great. So yeah, we're going to keep going. Let us know how we can help this initiative reach its greatest potential impact. Type it in, hit enter.
Okay, here come the questions. So I can answer a couple of these. I'm going to start with number 7. If the savings are assumed up front, will it impact payments to CMHCs? This will be cost neutral to the CMHCs. We've designed it that way. The savings really are driven by utilization of high-end services, and that model has been borne out by those that came before us, and we would expect those savings to inure that way for us. This program is only for adults. I've been talking to Jamia, and there are similar designs in the systems of care model from SAMHSA for children. And as we look at the high utilization and some of the other initiatives that you've already seen for children, we hope to inform that at PHDDH. The non-F2HC primary care will be involved. The program has a care coordination element for all primary care providers that have some scale in the program. In Iowa, we use 20 as the folks who have, if you had 20 patients in your primary care practice who were in the population, there was a care coordination fee paid to the primary care provider so that they could more meaningfully engage with the care management team. This will be part of the generalized re-procurement in the RFP for managed care, but it's a special population, so rates and contractual expectations would be separated for this population, and that has worked well in states that have integrated population focus into managed care. It really functions almost like a product because the benefit design is somewhat different. So, any other questions up there that I didn't get to? Okay, thanks.
Some great comments up here.
You were saying good summary.
No, I had something
Keep
to
going,
say.
no need to
Oh, Lindsay had something to add.
Oh, I'm sorry, Tom.
Yeah, I was gonna say ditto. but-
Well said.
So we just went through with 6 pretty significant initiatives. By the way, 5 and 6 are actually we talked about together. What I'd like to do is pass it to Ira. By the way, way to go. That was great. I hope you, We just covered a lot of material really fast. We got every single one of you around this working group table to tell us what you're thinking, honestly, candidly, and honestly. So I hope you feel heard, because you are. I'm going to pass it to Ira, who's going to give a question.
I just, this is a good time to do a mid-course check-in. So that was not at all what I expected. Why? Because it was smooth, it felt comfortable. I actually got to participate rather than moderate, which was fun. But I want to make sure that all of you are feeling like you're having the opportunity to say what you need to say, because usually in a group like this, what we have is a lot of voices, articulate, thoughtful voices, and the voices are sort of appearing on the screen. And I just want to make sure everyone's okay with that and comfortable with that, and if anyone has something to say, that they have a chance to say it before we move on and do more of the same.
So that generated a lot of questions. I would just add that this is, to me, a very powerful tool, and I would just underscore that all of the feedback has been highly professional, thoughtful, meaningful, and useful. And there is a value to anonymity, which is really an element that you don't often get with the verbal exchange. So that's another piece of this that's been interesting, and probably has teased out even some better feedback than you might normally have received.
Okay, full speed ahead.
Great. So that, we sort of closed out the significant initiatives, those big 6, we went one at a time. And we really, that was, when we were planning this meeting, we were like, if we get through nothing else, we need to get through that. So, okay, good. What's next is several initiatives all grouped around targeting fraud, waste, and abuse. We've got 6 up here. I'm going to give you a second to kind of look through them. And then we're going to call on Matt, who's going to give us a brief description about them. And then we're going to, again, use think tank to dive into a couple of these as we go. Matt, are you ready?
I'm going to defer to Bruce McIntyre, who's our Director of Program Integrity.
Great.
So I'm going to tell you.
Bruce McIntyre.
Good afternoon.
We have four major initiatives regarding program integrity this year. And I know there are six listed on the board, but there are some are lesser included. The signature one will have to do with predictive analytics. And what this does is allows us to visualize the payment system in ways that previously was unavailable to the payer. And that's because they were siloed. We had two MCOs and fee-for-service system, and claims came into the system and they were paid, and we reviewed them on a post-payment basis. And what we're trying to do now is shift from the post-payment review to a prepayment analytic where we can visualize what's coming in, make some decision makings, and extract important data out of that before the claim is paid. So rather than pay and chase, it will be analyzed on the front end. We think this is an important shift in the way we go about doing business. The other thing the predictive analytics will do is it allows us to extract data out of the system that's available to us now, but it's not available in the way that allows us to get it out easily and make important decisions on utilization. So we think that's going to be a very helpful tool as we go forward. The second one is electronic visit and verification for home care. As the system sits right now, we have an important and robust system of home care delivery, but we don't have a very good way of making a determination whether the visits took place in the way they were supposed to take place, at the time they were supposed to take place, and did the service that was supposed to occur in that home actually occur when it's being, in the way it's being billed for. And the electronic visit verification will utilize simple technology such as an iPhone and allow us on a GPS basis to know whether the visits are taking place in the home and what the people who are recipients of the care are getting the care when they need it. And the third major technological innovation is around recipient fraud and whether people are collecting benefits who are no longer living in the state, who perhaps have died and are still getting bills for them, and allow us to utilize data that's available on a national basis, locally and internally. So those are three technological initiatives that we feel are going to really be a game changer for us at OHHS. And the fourth one is the authority to have subpoena power for the office. So when we do look at an important case, we can get documents in a timely basis and allow us to do the kind of job that we're expected to do by the taxpayers and other providers who are doing things appropriately. The enhanced residency verification that's listed out will fall into the latter category. So that's another data source that is available out there, but it's not being collected. So we expect to go up to RFP for that as well. So we feel the three technological innovations are really going to be the kind of things that will help us garner the data that's otherwise available but not utilized as effectively as it could be, thereby giving the state significant savings on a go-forward basis.
And Bruce, we got a couple questions for you that came in.
Sure.
Here we are. Pick which one you want to talk about.
What are the assumptions being made relative to IT and other resources and capacity to effectuate these items? So among the issues is always making the most effective use of the staff that we have. The team that I head up at the moment is located with our partner, who at Packard on Metro Center Boulevard. What we have tried to do was hire the staff that has some experience making these types of judgments, such as the pharmacist and a seasoned investigator and people who, and a nurse who have done this kind of pre-analytic review in clinical settings in the past. So we feel that as we go forward and we begin to learn and get better at utilizing the technology, we can make determinations about staff. But I think at this particular point, existing staff can do it.
Bruce, let me ask you number 5. How do the residency requirements compare to neighboring states?
Well,
The residency requirement is a more complicated issue than one would have expected, because people have a constitutional right to travel. And so the residency requirement really has to do with a beneficiary's intent to reside in the state. And I know that's a more difficult concept, but in theory, you could be collecting benefits from Rhode Island and not yet be in the state. And that is allowed. I think what we need to do is tighten our policy a little bit, but still keep within the confines of constitutional due process and the right to travel.
And we got a lot of questions, but if anyone has something really pressing, they want to raise their hand and ask Bruce. Yes?
Does the electronic verification for home care cover all home care CNAs and personal care workers in the personal choice program?
That is an excellent question. And one of the things that we've learned was just how many pieces of the program had started in ways that were not coordinated perhaps as well as they could have been. And so under Secretary Roberts, she's to lead the task force, and we are trying to get a more comprehensive plan together to incorporate as many as possible. So I know Buddha's does its own right now, and it's actually going
Who
through.
pays for that little device?
Well, it would depend. Now, we would expect that the person delivering the care would be able to have, for instance, a mobile device such as an iPhone. This has been the expectation in other states where this has been successfully deployed. I believe that will be the method we go with and around. However, we recognize there are pockets, even in Little Rhode Island, where the cell phone signal is not optimal. And for those, we'll have a little transponder that the recipient will have that will be able to communicate with the centralized system. And in those limited circumstances, the state could be paying, I think it's about $15.
One more quick question from the floor.
I just wanted, if you wouldn't mind addressing question 5 again. The question was compared to other states, not Rhode Island's criteria. How do we compare to other states?
As far as residency?
It's a federal standard.
Yeah, the standard is a federal standard. However, the states are free to make it slightly more restrictive, and we've been working with New Gifford and others to have language put in place in our regulations that would allow us to make some meaningful adjustments to that. But the standard at the moment is a federal standard.
Yeah, one more.
Well, I guess just following up on that, are you talking about the process for verifying residents or the standard for establishing residents?
So I would say
Which is different.
there's two pieces of this issue. So one is looking to see whether our standards for how we define residency for the purpose of Medicaid eligibility are correct, whether they are too loose compared to our neighboring states, whether they are about right. And the second thing is using data we get from from claims submitted and paid by our managed care organization for fee-for-service to see whether there are people who are Rhode Island residents who are Rhode Island eligible for Medicaid who are receiving most of their services out of state, and we follow up to verify their residency. That's the two pieces of what happens.
So what we're going to do now, thank you very much, Bruce. What we're going to do now is a panel has opened up on the left of your iPad. And things on the left contain things on the right. It's a little unintuitive, but I think you'll get it. So what you can do is you can tap on any of those 6 categories. You can see that 1.1 through 1.6 are the 6 initiatives under the category of targeting fraud, waste, and abuse. So what we invite you to do now is to pick one of those 6 and then tap on it. Give me a second to pick one. And once you've got that, it's one you feel passionate around, you have a particular urging to say something. And then once you tap on it, then the text box, again, tap on the text box at the bottom right, keyboard comes up, and share with us, once again, how can we make these initiatives achieve as much impact as possible. So you get to choose which initiative you want to talk about, and when you're done sharing a comment, hit the turn, you can close the keyboard, you can go back to the list, and you can go into another initiative, and you can add comments there. So we're going to give 3 or 4 minutes for this, add as many comments to as many initiatives as you want to, and then we'll keep moving. All right, so close out your comments, and then I'll invite my Deloitte colleagues. When you look at this list, Sally, Jim, what do you see that we want to highlight?
Hang on a second.
Okay, when it comes to 1.4, this is something that you can look to other states, rightly, who have been doing this sort of pattern recognition, predictive modeling. There's actual software packages out there that you can purchase and then configure for your state, or you can go with whoever that would be and use their particular method of pattern recognition to identify those instances that go beyond just making sure that somebody's not claiming the same medical service for the same day at the same time for the same person, but actually go beyond that and actually start pulling all the data together to find that particular thing. So that's what we're seeing here. We're seeing really positive comments about predictive modeling, but it's going to take a lot of insight and a lot of work to get deeper into it.
Thank you. And you also notice there's a final comment category there. What else should you be considering? Some comments about DME fraud, EBT cards, that kind of thing. So we're getting some other ideas as well in addition to those types of issues. Quick comment, yes.
Yeah, just to put a finer point on this, we talk a lot about beneficiary fraud, it's also provider fraud. There's another whole layer here. And so just to give it an example, our company, Blue Cross Blue Shield of Allen, we invest, probably $750,000 a year in a fraud unit. It has like 6 or 7 people in it. That's all they do all day long anyway. They got like $4 million last year. They get 3, 4, 5 million every single year. So, the question is about, do we have a sufficient investment here in terms of those where investment can be important? Do they have the right tools, and then can they go reinforce? That's the key.
Thank you. All right, I'm going to keep us moving. We just talked about fraud, waste, abuse. We're going to move on to another category, which is, sorry, one last
real quick. Fraud, waste, and abuse. This is for CMS. Definitely last few years hearing more and more about that they want to look at states and make sure this is happening. It's always been given lip service for years, but they seem to be moving more in line with it. So it's definitely a good area to be looking at and being most efficient and effective as we can.
All right. Transition into long-term care initiatives. Thank you. So we have a list of, I believe, 11 here. Take a look, and then I'm going to call on Matt to take us through it as efficiently as you.
So I'm not going to read all of them because, but if you think about this, sort of at least 3 sort of main areas where these initiatives fall. One is, what are some policy or structural or payment changes that we can make to encourage the use of lower cost settings for long-term care, particularly home services? So, what can we do to encourage the development and use of assisted living? What can we do to encourage the use of health-based services? What sort of unintended consequences arise from existing policies that may push people in need of long-term care into nursing homes who otherwise would be in the community? The second is, can we look at our eligibility rules and whether there are areas where we need to tighten those up to align with what other states are doing, or to look at sort of complex issues around sort of financial planning and estate planning things where you get kind of an arms race with the estate planning industry, how we can make sure that we are capturing all the assets necessary to make determination of eligibility for Medicaid. And then there are just how can we adjust and put more control over the financing around the system. So looking at ways to optimize federal revenue through an increase in the bed tax. We're looking at are we paying for services like hospice, like adult day, at the right levels, and will changes in those areas drive the service and drive the at the right levels. So there's a lot up here. There's also some less immediately transferable things like encouraging sort of advanced directive planning after long-term care, looking at how we compare to other states and what we do. So I'm sure there may be questions that we can go into.
So once again,
Question down here?
yes.
Hey, Matt, can you clarify the hospice one, reduce hospice payments to 95%?
Yeah, so when we were looking at this in terms of looking at the program and the feedback we got from the public, there's a sense that we might not be paying for hospice in the best way possible. There may be areas where we are overpaying or duplicate paying for hospice specific to the nursing home. We're not sure that we have that initially exactly right, and I think we may have some of the calculations around our predicted estimate wrong. So we're actually going to take a little group off table, and we're hoping that you and Hugh and Diana can get together and help us make sure that we have that one exactly right. So there will be a circling back around to that initial to make sure that we have that.
Thank you. So, same drill as last time. We've got a panel again on your left. Please read through that list. If you needed to use 2 fingers to scroll up and down, you can do that. Once you've found the one you feel the most passionate around, tap on it. There's a text box at the bottom right. Type in, how can we make this initiative as successful and have as much impact as possible? Let us know your thoughts. Hit enter.
Okay.
All right, so please finish up your comments. Some great ones coming in. A lot of energy around managing long-term care services through integrated care initiatives. That's 1.8. A lot of energy around 1.3. Changing payment structure to support expansion of assisted living. I'll turn over to my colleague. What are you seeing?
Definitely what we saw in the 1.2, which was MOLST, if I'm saying that correctly. I mean, you can look through there. Require it, drop the encourage, go with require, make it mandatory. 1.8, the ICI needs to be more prominent, and it sounds like it also needs to be expanded to include behavioral health. That's one of the ideas here, and that long-term care facilities need to align hospitals and nursing homes better. And then 1.6, everybody loves PACE. And everybody thinks it should be bigger. And it works.
Love it. Love it. Thank you. Yeah. So we just went through a whole bunch of initiatives. 6 plus 7 plus 8 plus 11 is a large number. There are 34 more that we haven't talked about, and that's intentional because we have a limited amount of time, a limited amount of attention. We wanted to focus on the big ones. But those 34 initiatives will be on the website for review. The next step is we're going to do a couple more questions in Think Tank, and then we're going to open up for some public comments, I believe, and then we're going to close out the session. So let's finish up the next Think Tank activity. So kind of open-ended. Question coming up on your screen. What areas for short-term savings are not on the lists that you've seen today that should be? What areas are not on the lists that should be? All right. While you finish up any last comments, I'd like to ask you one question in here. Secretary, would you mind helping us out?
Yeah, so what's now number 1? Have we seen all the proposals made by MCOs providing goods or systems? The answer to that is no. One of the fascinating things that's happened over the last 48 hours is that we have had a deadline-induced arrival of a number, some of them quite significant in size. So, and we did not feel comfortable not having really even reviewed them, putting them on this list. So you will see next week, and actually in the work streams we'll be talking about a couple, at least a few major proposals from providers that have come forward for review and potential inclusion. So if you're aware of some that are floating around and you don't see them here, that is most likely why. I can't, I'm trying to think if there are any, there's certainly, let me also say, we've received over 200 suggestions, and you have not chosen to follow through on all 200 of them in the proposal that you're seeing here. And the other thing that I will comment on is that, as you know, we have a target for next week of submitting a series of recommendations to the governor. We have another goal of providing a long-term roadmap by July 1, and you will see some other proposals that get integrated into that.
Thank you. All right, in return on any last comments, I'm going to move you. Going once, going twice. Last think tank question of the day. What one thing are you personally committed to doing to move this forward? So think of yourself, working group, this is your role. Think of one thing you're personally committed to do to move this forward. Remember we talked about the legacy earlier, what the legacy of the group will be. What are you going to do? So, we're seeing a lot. Let's see, a little bit of time to categorize. Some folks are talking about expanding offerings, continue to offer care, do what they continue to do. Definitely some comments around, a lot of comments around advocacy, communication, and listening, because that's part of communication. And that's great to hear that there's a lot of energy in the room for advocacy. Assessment is another one. People want to continue to bring a sort of data analytical lens to it. And then also collaboration, wanting to work together with partners, perhaps people you haven't necessarily worked with as much before, as well as a lot of other ideas. And remember, 2 fingers to scroll, you can see the whole list. This is great. I am very impressed. This is this group, high caliber, high impact, ready to make a significant impact here. So wonderful working with you. This is where Hub comes and takes me off stage. So thank you. This is Think Tank. The iPads are not yours to keep, so please close them. Just leave them there. We'll pick them up afterwards. And let me pass it to the secretary, who I think is going to invite some public comments.
Yes, thank you. So let me begin by thanking everyone. This is a very different process than we usually use in our public meetings. It must be particularly different for the audience, because we get to watch that, but otherwise don't really have a significant piece of the conversation. So this is the time in the public meeting for public comment, and so I wanted to open the floor to public comment. Yes.
My name is Jim McNulty. I'm the Executive Director of Mental Health Consumer Advocates of Rhode Island. And I've been following this process right along, and I want to thank everybody who's serving on the panel. I think you've done a lot of work very clearly. Without having had access to all of the documents, I would suggest that there be more opening for advocacy from the community into the implementation phase. I think a lot of the ideas that we've seen here, particularly the ones I'm most familiar with in behavioral health, I like the looks of. One of the things that the feedback I get from my members is that there's been a lot of whiplash from clients who've been receiving services because there's been a lot of changes in direction. There wasn't an understanding necessarily on the part of providers on what the health home teams needed to do. And there's a lot of confusion around that. And I think that the department appears to be headed in the right direction now. And I'm going to stay tuned to that, so thank you very much. I would also like to make the point, I haven't heard much of this, peer services are something that are starting to evolve in all areas of healthcare. And I don't think that that's been talked about here. Certainly primary care, we already know that Rhode Island Parents Information Network is very involved with the NICU and neonatal issues. Mental health, we provide peer services to people who live with serious and persistent mental illness. Our colleagues at Anchor provide support for people with addiction and alcohol issues. So that's something I would like to encourage this panel to look into a little bit too. But again, I just want to say that this is a hell of a lot of work. I don't envy you for having done it. Implementation is, as we all know, going to be extremely difficult. I will continue to be involved and support the process as long as I believe it's headed in the right direction. So thank you.
Thank you. Any other? Yes.
Hi, I'm Tina Spears from the Rhode Island Parent Information Network. I'd like to echo Mr. McNulty's comments about having consumer advocacy at the table during the implementation phase. In particular, for the children with special health care needs, as we move services in plan, we really need to think about that thoughtfully and ensure that we're not restricting access, restricting benefits in any way that would prohibit community-based programming. And I'd like to really echo serving in the capacity of an agency that is a community-serving agency that works with children and individuals with special health care needs. Community is where individuals want to be and belong and thrive. Having a child with special health care needs, I know all too well that caring for them in the community requires a lot of work. So we need to build the infrastructure, make sure that we ensure that those services are built upon and accessible for families. So as we move towards moving them in plan, just be thoughtful about that. In addition to that, I'd like to just address the fact that in Rhode Island, we don't really have a strong palliative care program. If there was one thing that was missing from this Medicaid reform, we did not look at palliative care and integrating that with our community-based programming as well as our primary care practices. So maybe thinking about that a little bit more strategically. And the only final thing I would say is really building up our primary care infrastructure, making sure that everything that we do coordinates alongside our primary care.
Thank you.
Yes.
Excuse my dad. I'm Kathy McCarran, member of the Diocese of Providence. I've been there 9 years and I oversee community services and Catholic charities. And for 31 years prior to that, I worked at the hospital. So I'm going to talk specifically, just 3 specific comments, but I want to talk about primarily elders or adults with disabilities. First of all, I did send in written comment on a program called Families, which is the diocesan-run respite support for family caregivers. I bring it up as an example of programs that are not necessarily or currently Medicaid funded, but have a big impact on who comes to the Medicaid queue down the line. And programs like Meals on Wheels, programs that are funded through the Local Americans Act, and programs funded through state money that is not used to match Medicaid. There are lots of programs out in the community that are supporting older people, some in some version of long-term care now. Many of them underfunded. There are some that are heavily funded. We've had a wait list in our small respite care program for family caregivers since October 1st. We get state and federal funds, but not Medicaid funding. Now, I'm not suggesting that we develop a Medicaid version of this, because there are people who do not qualify for Medicaid that need help with these services. And the longer they go without service or without help in getting the services, partial payment or whatever, the closer they come to being poor and sicker and down the wrong end. So that's my first point. My second point is that, you know, the Medicaid dollars, and again, I should echo what everybody's saying. This is, you've made it rocket science. It is complicated. I'm sitting there thinking, oh my God. Every single issue is complicated, and I know that there's a lot of hard work that has to be done. I know the pressure is cut the money, you don't have it. But a long-term solution is never going to happen in one budget year. And if you take it from me, 40 years I've been doing this, a one budget year will not give you a long-term care solution for any program. So to supplement care for caregivers and build a real community-based system that helps people keep people at home, you need more than 1 year. You need more than 1 year to make sure that we have in Rhode Island what will keep all of us healthy and have quality of life. And so only those who then need Medicaid end up on it. And my third point is, you know, I'm looking at those budget ballots. Now, we get less than $400,000 a year to take care of a couple hundred families to help pay part of the cost of respite for family caregivers, some of whom are in their 90s, who leave the house once a week, if they're lucky, to get to their own doctor because the person they're caring for has Alzheimer's and dementia and cannot be left alone. So those numbers are staggering, let me tell you, when I look at them. And I see when you talk about pulling savings out, you make a cut, you put it into another program, save $10 billion, $1 million, or whatever. But as a taxpayer, once that money is taken out and saved in some way, I don't feel it's owned by Medicaid. I have to be honest. So those state dollars that might have been freed up, yes, put some back into an incentive program for nursing homes and home care and everybody else. But how about putting some of it back into the community-based system that will help all Rhode Islanders age with care and quality of life? And that's it. I will say
Kathleen, you'd be happy to know that I did put that idea on the list.
Thank you, Maureen. I was reading there, I was saying, I was hoping I wasn't the only one thinking of these things.
Yes, so there's two people. You can we will short.
Thank you. Hi, I'm Rebecca Kislak. I'm the Policy Director and Counsel of the Rhode Island Health Center Association. RICA supports Rhode Island's community health centers, including 8 federally qualified health centers and 1 island-based health center on Block Island. Our community health centers provide comprehensive primary medical, dental, and behavioral health care services to 151,000 patients, including 84,000 patients enrolled in Medicaid. And we think that that means that we provide primary medical, dental, and behavioral health care to about 1/3 of Medicaid enrollees in the state. The community health centers in the state are important partners in ensuring that Medicaid enrollees access the care that they need in order to achieve the best health outcomes possible. And we're looking forward to continuing to work in partnership with the state. We submitted comments earlier today that are quite extensive. I have a bunch of copies with me for the working group members and for members of the public who are interested. So you can come see me later. Thank you very much.
Vinnie Ward from Home Care Services of Rhode Island up in Woonsocket. I guess one of the things that I want to mention is the EVV issue that came up today was probably the only thing that I heard that really dealt with cuts, pluses or minuses to home care. And that becomes another expense to me because every phone call is going to be an expense. So all that means is I'm going to have hundreds of dollars a month in cuts more. And the question came up as to who's going to be responsible for these smartphones. I haven't asked all of my CNAs if they happen to have a smartphone, but since they haven't gotten raises in 5 years, I don't know if they have one or not, or whether they'll be able to afford the minutes that are going to be used to make a phone call, to call the office to say that when they got there or when they left. But it's just another issue that as minimum wages keep going up in the state of Rhode Island, it's been about 4 years now they've been going up. Wages in home care have been stagnant, and therefore they're getting less and less attractive as a career for people. So just as you look toward increasing expenses for home care agencies, just keep in mind EVV is another cost to the agency and another cost to the CNA in their minutes that they're going to be using too without raises. So just wanted to let you know that. When the minimum wage goes up and our pay stays stagnant, it creates a big problem.
Okay, so I'm going to just say a few words before I turn it back over to the co-chairs. One is to just emphasize, so for example, Rebecca said she just submitted a bunch of recommendations. We have received a lot of recommendations over the last 2 days. So you're going to see many of them reflected as we move forward. It is not because we were hiding them during today. It's because they just came rolling in. And we are doing our best. Over the next week, our doors are open. So you put a lot of information up here, and that is very useful information to us. I already have meetings on my schedule, as I'm sure some of my staff, with many people in this room. We are here to kind of get this as far as we can get it for next week when we are going to make recommendations to the governor. But I also really want to remind people that we have the next phase. So we are doing a little bit of bait and switch, but you sort of knew this, that when we first reached out, we said we have to have it done by May 1st. And then we ended up with another opportunity for a more in-depth, more, actually, a bigger picture of where we want to go in terms of improving health, driving an improved system, changing payment delivery, and a really big picture. And you're going to see some of that laid out in the report next week, buttressed by some of these, but I think, as you know, you're aware that many of the pieces of that system are not represented here. But there are parts of it that are represented here. So we're really going to start to lay that out. July 1, that will be laid out in a lot more detail. So we are meeting again next Thursday, the 30th. That is our date that we are tasked with the governor to complete our first phase of our work. I do want to tell you, and it's a very practical thing, because of scheduling, we have moved the time of that meeting to 2 o'clock in the afternoon. So you'll get a formal notification. It was originally 4 o'clock, we're moving to 2 o'clock. I apologize right now for everybody that complicates their lives. It is a really busy time of year, and we've got legislative issues to worry about as well, and that seemed the easiest approach. The work streams are also continuing. So we've got a high utilizer group tomorrow morning at 7:30. You have everybody who hasn't gotten enough today. Friday morning, we've got a payment delivery system reform meeting at 7:30 in the morning. So these groups are all meeting at actually tomorrow morning. And we have long-term care at 10 a.m. Are all of those posted on the website? Do they or not?
No, the work stream meetings have.
Okay, so
the notice is been sent.
right, the notices go around. So, and behavioral health is coming up as well. So do we have another behavioral health next Wednesday? Yeah. Okay. So they're all going to keep going. And when somebody mentioned, actually a few people mentioned implementation. So let me also say that this has become one of my biggest obsessions since taking this job, is that we not only have to have the good idea, it's even more important, and I think where we in government, and not just government, but particularly government, have not always made it, is that we have the idea, but we don't get it done. So we are, and this is going to be a collaborative process. So when you mentioned, don't leave us out of the conversation. So I've already reached out some around the children with special health care needs, the seniors issue. We just ran out of time. That conversation needs to happen in the next 72 hours. And then, but when you look at all of these and over the next 6 months, next year, we are on a shared mission. We're not always going to get along throughout all of it, but we are going to do it best when we do it together. And so I know this is a break week as well, so we've got Marie Ganem, and I don't know if anybody else is here from the legislature, but our legislative partners are also incredibly important in getting this work done. So the work streams are continuing. We've got a July 1 deadline to really get some very big picture planning done, and then to have not just a plan, but a map for how we're going to get that work done over the next 1 year, 2 years, 3 years, 4 years. We can't commit beyond this governor's, I can't commit beyond this governor's administration. Actually, many of you can, because you will be advocating, leading, providing care across the system. And so we owe it to you to do the best we can over the time we have to keep moving. And I want to thank everybody for today. This was really different. I'm used to talking all the time. So this is really different. It will be very informative for all of us. So thank you for coming to it.
And again, on behalf of my co-chair, Dr. Wilson, we couldn't be more appreciative in terms of all the hard work that's gone into this. But at the end of the day, we have a goal. We remain focused on the goal, and even in my work stream meeting, I'm sure in your work stream meetings, there's a lot of good dialogue, there's a lot of good advocacy, there's point, counterpoint. But I always try to bring people back to we have a goal. And we have to come up with these ideas to send them to the governor, and they have to be the best ideas. And they have to really be targets for the FY16 budget. I think a lot of people said, and certainly in my experience, you can't do reform in a year. It really takes multiple years. It takes a good 5, 6, 7 years. But if directionally what we propose is in sync with what we're trying to accomplish long term, I mean, that is how we're trying to approach it. So I would just make those points. And the long-term reforms will require, redesign, innovation, transformation, a lot of the things that kind of get us out of our comfort zone in terms of how we've always done things, but that is the challenge, and that's what how we really need to look at the future in terms of really being successful with AAA and really improving the care for vulnerable populations. Today has been outstanding, exceeded expectations, I think. I really wanted to do a real shout out to Deloitte for supporting this process. And again, from my co-chair here, We had a lot of questions when we signed up for this. I think we signed up for it. About how would this go? And I really want to give a shout out to Secretary Roberts and the entire EOHHS staff. They have been nothing but spectacularly helpful every step of the way here. And I don't know when they sleep because they're still up emailing when I'm in bed. I'm a late, early riser and late sleeper. So anyway, I just want to give a shout out to EOHHS and the way. Let's do that.
It is 4:29, and we are on schedule to finish on time. Thank you very much.